Okay. So I welcome Tasha Wyatt to What Role Should Resistance Play in Training Health Professionals? And she comes from the Department of Medicine, Uniformed Services University. Thank you for joining. Tasha has the floor.
Well, thank you so much for having me. And Tom, thank you so much for your interest in this article. I'm really glad that it was picked up. Let me first begin.
Could you raise your volume a little, Tasha?
I can come closer. Sometimes the volume doesn't always come through.
And everybody, comments or questions can go in the chat, and we'll have breakout discussions, not in breakout rooms, but spots for discussion coming up. Go ahead.
So let me give you a little bit of an overview and a background of this article. In 2018, 2019, I received a grant from the SGEA, and I study the Black and African American physicians' professional identity formation experiences. So that's really the kind of empirical work that I'm most known for. And as I was collecting data, I noticed that these physicians were engaged in acts of resistance. And I thought, oh, that's actually very interesting. I kind of like this. Flexner report excluded Black physicians for nearly 100 years. And they are now welcome in this space, and they are pushing against some of the norms that they have experienced. And at the same time, during this time period, I was doing exit interviews for some of our residencies that were on some shaky ground and trying to figure out what was going on in these residencies. And in talking to the residents, I found that there were some very harmful and unjust experiences that they were having. And so in putting these two together, I started to wonder what kinds of tools we have available in medical education in order to talk back to the system. And are we just expecting our physicians to be resilient in systems that really aren't treating them all that well? So I wanted to write a paper about it. So I didn't know Rachel Ellaway. She is a fierce woman. She is an out-of-the-box thinker, as was mentioned earlier. And so I just emailed her and I said, I really want to write this article. I feel like I need top cover because I'm sort of new to medical education and I need somebody more established in the field. Would you write it with me? And she said, absolutely, this sounds wonderful. So we actually wrote this paper beginning in spring, summer of 2019, before the social upheaval with George Floyd and all the killing of Black people by police officers. I mean, of course, it's been going on for a long time, but it really kind of crescendoed in the last 18 months or so. We started writing this article before then. And then we've had to slowly change our thoughts and integrate sort of what's going on in society before this came out. I will tell you, just as my final note, that this was the hardest article I've ever had to get published. It was initially rejected by academic medicine, even though it was some of the best reviews I've ever received on my work. I pushed back with the editor-in-chief and they suggested that we resubmit. So we resubmitted under a different title. We were given major revisions, followed by minor revisions, followed by major revisions, followed by minor revisions. It was the most challenging article we've ever gotten through to publication. And I think it's because it's the nature of the topic. So what is resistance? Resistance is a deliberative reaction aiming to remedy something that's confining, such as social structures. It is not only an attitude against something, but a desire for something. And the article we wrote is really talking about the importance of physicians resisting a system that is unjust and unharmful, and the need to have more language and theoretical conceptualization around what this looks like. All right, it's not moving. So give me a second. It is not the same thing as disobedience. And I think that that's why we were getting so much pushback from the editors, because they thought that we were talking about disobedience, which is why we have that paragraph in there where we're contrasting it with disobedience. It's not the same thing. So disobedience is a form of resistance, but needs to be ethical and principled. If it isn't principled and ethical, it has no integrity in a professional setting. So for example, my 14-year-old daughter can be disobedient, but that doesn't mean that she's being principled in what she's pushing against. And to be resistant, it has to be grounded in principles and ethics. So we have defined resistance as being affirmative and principled. It should be something, it should be for something rather than against something. Ooh, sorry. It should be deliberate, undertaken intentionally and mindfully, not willy-nilly. It should be sufficient to achieve its ends, and it should be about finding and building solutions, because ultimately it's about creating change within the systems that we work within. So I'm going to give you a couple of examples of what this might look like. Ooh, I'm sorry. I'm just trying to move you guys so you're at a different part on the slide and I can see my words. So for example, a Black resident returns to a Black patient's room to check to see if the patient understood the course of action. So they're going in to make sure that the system is serving them and that they have understood everything that has been talked about in the clinical encounter. A medical student refuses to use the term provider because of its tie with Nazi Germany. I don't know if all of you are familiar, but there's been some recent work that's come out that that is a term that was used during World War II as a way to be dismissive to physicians. So now the term that's being forwarded is practitioner. A woman physician recruits more women into subspecialties that have historically been male dominated, again, to push back on a system that has been created to exclude certain groups. A medical student uses they, them, even though the rest of the team is still using the pronoun she, her. And again, this is talking about trans individuals. And a group of students reviews the UME curriculum for the ways race is discussed as biological and not a social construct, and presents it to the dean's office. So these are all examples of different forms of resistance. And as you can see, it's not just against something, but it's for something. It's speaking to the larger system that has created the unjust and harmful depictions of people, of patients, of practices, and trying to come up with better solutions. So what is the difference between resilience and resistance? So when we talk about resilience, we talk about recovering from difficulties, elasticity, right? The ability to bounce back. But there is no sense of defined change. So Tom has posed the question, does resilience reflect resistance?
So this is an open discussion now among all of us. Tom posed this. Tom?
Yes. I guess my question is that you certainly can be resilient against certain things that are unfair. But when should that turn into resistance rather than just resilience? Because resilience does not change the system. It allows us to adjust to it. And are there times when just resilience is not enough?
This is an open discussion. I could look at the chat if people prefer, but it is an open discussion. So just unmic and speak out if you like, or put a hand in or something. But Elizabeth, thank you.
So, well, thank you very much for this important topic. I was really looking forward for this discussion because I think it's really very important. My question I want to throw in here is actually, where does the responsibility of the individual end And where does the individual who is resisting or resilient kind of goes again with the herd and gives up responsibility. So I think responsibility is one important thing here. You can resist, it's easy. We go with the herd again, we go with people against stuff, easy, right? Is there a solution, right? Or when has an individual a responsibility to actually move forward and really cause a change in the system? Thank you.
I think that is a very poignant question. Does anybody want to answer, Elizabeth?
I mean, can I pose another question? What do you think happens on the wards when there is this type of experience?
So to be clear, Tom, on the wards, are you saying, is it possible to be resistant on the wards, or?
Right, when you are treated unfairly, is it possible for let's say a resident or a student to actually resist, or does resilience is their fallback?
This patient wanted
That's
a letter
a
back
good
from us, but
question.
he was wondering if we had any restrictions because he has to climb go on stairs.
I'm not sure who needs to be muted. Let me go into.
Okay, so
Someone's talking about patients. Mute yourself, please. Thank you. Does anybody want to bring up that idea of the difference between resilience and resistance on the clinical wards? Because most of you on this call are from a clinical setting, not everybody, but I think that's a good point that Dr. K says.
I would like to say that yes, as a resident, it is very difficult to have any resistance, especially against things we find unjust, especially when we're rotating on other services. If a person of color is a patient of ours and their pain needs are not being met, even if we bring up articles that show that that is a thing that happens, the attending physician decides, no, we're not treating their pain. That's it. That's the end of discussion. We don't really have any options past that.
So that's a great point, right? There's a power dynamic that goes into the trainee versus the faculty versus the departmental culture. Even as an attending, these things aren't easy, but I would say, it depends. It's a very personal answer too, right? For some people feel that resistance is just the way to go every day. I mean, anything you see, you should try to correct. I mean, that's a deeply held belief for many people. Other people, even though they might believe that, don't feel they're in a position to do it. And particularly hard, right, for students and for residents or fellows, people who may be transient within the health system, or maybe simply feel like they're not in a position of power, or not feel like the local culture reflects a desire to change and improve. So, I mean, it's a tricky answer. Personally, I think you always take a position of resistance, but I come from a certain position, I guess, in a certain role where maybe I have that luxury. Probably wasn't that way when I was a student.
Do you think, I'm sorry, go ahead.
I just want to say I love the idea that David brought up the issue of power dynamics. Like suddenly as a student, he speaks one voice, and then as an attending, does he have a different voice? And so that idea throughout medical education, the voice, does it have to change from being a student to a resident to an attendee?
But so I guess my question from that is, there are, as was described, correct ways to resist and ways that aren't correct. And should we be giving our students in medical school the tools necessary to resist in a way that is acceptable and can result in change?
So Tom, you're suggesting explicate it and give them the tools to use so that we have a common framework for working within the system when we notice these kinds of harmful issues.
Yes, that's what I'm saying. Meaning that, I mean, resistance can result in negative attitudes if it's not done correctly. And if there's a way to make this a type of behavior that is acceptable in our health system, and that we give the students the correct tools to make it done in a professional manner, should that be part of our goal?
Well, I'd argue, Tom, that it's absolutely essential. It's something that's been missing from medical education forever. And why don't we focus so much? I guess many of us, right? Many physicians believe that physicians play an important role in society, but I think maybe we're in a minority. And I think over time, people are much less likely to engage, I guess, as we get older or more mature or whatever it is. And I guess there are many, many reasons there, but I think medical schools have basically abdicated that function or have chosen to ignore the individual's, the physician's responsibility towards society. It's missing. As student organizations come up, whether it's various, AMSA or the AMA or whatever, like those places, students who are more socially cognizant have an outlet, but unless they take the initiative, I don't think medical schools really foster that, even though they should.
I mean, you're preaching to the choir here, but I guess it has to be something that is explicit, and it has a curriculum that, again, is all about doing things in a professional manner.
100%.
Right. And it also has to be explicit from the perspective of the leadership, not just the actual doers. So I think we'll progress here and come back. We have more questions, and put things in the chat, and I'll let our speaker progress.
So Joanne, I did see your hand up, so hopefully we'll get back to you. And then Elizabeth, I also recognize we haven't answered your question yet. So we talk about the importance of advocacy in medical education. So David didn't outright say that word, but we don't talk about resistance, right? That has been a no-no in our discourse, but advocacy we talk about all the time. So what is the difference between advocacy and resistance? So I want to get your thoughts on this.
Go ahead, Judy.
I was going to say, I don't know if this is the right way of thinking about it, but advocacy, I mean, first of all, besides the positive and the negative spin on things, I think of advocacy as a system change, and resistance as being something that can be more personal, like a one-on-one, even though resistance can lead to a more systemic change. But when I think of advocacy, I really, my mind goes to a more systemic change. Although even as I'm saying it, I guess it could be a spectrum, but that's how I differentiate.
Mm-hmm. Does anybody have any reactions to Judy's thoughts? So we actually defined it slightly different. So we defined resistance and advocacy as both trying to affect change, but resistance is a challenge to the status quo, to the system, while advocacy seeks to ways to adapt it or change it. So we often talk about moving the needle a little bit, but resistance is redesigning and rethinking the system as it is. So we see that as being much bigger. Looks like David's got his hand up.
Just a question. Would you then, is that what we used to call revolutionary change, I guess, or what some people still call revolutionary change? I mean, really, they're in the same. Are you just talking about incrementalism versus kind of larger steps and shifts?
Yeah, it's not just the smaller steps or like a giant step, but it's also thinking about the system more holistically. So advocacy we see is like maybe going in and, can we get a different case in our PBL group, because this one isn't helping us achieve our goals for this particular standard. It's a small change within the system versus going in and saying our entire PBL curriculum is racist. We equate biological constructs with different disease processes, and we're reifying social stratification. Something like that. So that's resisting the larger system that's at place. So we also see resistance is dealing a lot more with kind of issues of ideological bias and things like that. Whereas advocacy might be around a smaller issue within the system, but primarily keeping it intact.
You're muted, Alice.
I think of advocacy as going through established channels where resistance doesn't necessarily do so. What do you think of that comment?
It resonates with me. That's exactly the way that we would think about it.
Right.
So not asking for permission to be able to make change, but to actually do it outside the established channels.
And then another colleague said, I agree, advocacy of working for areas that are identified and generally accepted as areas that need attention and change. Right. So is this becoming clearer to people? Because I think it's a major point of today, because we do promote advocacy in general. I mean, my whole life, different things I've done with advocacy work, I haven't thought about saying, okay, when does advocacy change to resistance?
And I think one thing is, I'm sorry.
Go ahead.
I think one thing is that resistance, you have a solution in mind. That you are resisting something, but not just for the sake of resisting it. That you have the actual plan on how you feel things should be as opposed to how they are.
So you look ahead to an outcome that you desire to reach.
It's not just against something, it's for something.
Right.
So I would advocate for such. If I don't have a solution that I personally feel is the correct solution, then there's no resistance in and of itself is kind of meaningless. There has to be an active or proactive approach to resistance where you feel this is being done this way, but it should be done this way instead.
Joe, I know you had your hand up before. Do you want to add to this, or you want to wait till later?
Because when you were talking about resistance earlier, I was thinking about how, you need to me, I need to define it as whether you're talking about the individual level, within some defined group. So a resident dealing with an attending, dealing with the patient care team, or at the systemic level. And I think that's where you get, then that sort of feeds into this whole discussion of resistance versus advocacy. But I was thinking of an example that I think shows the difference between resistance and advocacy. And I probably have the details mixed up, and so somebody can correct me. But a few years ago, there was a couple of very, very expensive, I think they were chemotherapeutic drugs. And so, advocacy would be working to make drugs more affordable. Resistance would be the team at MSK who said, you know what, we're not even going to prescribe these anymore. We're getting rid of them. We're not even going to traffic in these drugs because they're obscenely expensive. So to me, that's like, we have a group, we have a person from the IDSA who comes in and talks about advocacy for antibiotic resistance and lobbying Congress, et cetera, et cetera. That's advocacy. And that's how I started thinking about the whole situation with those chemotherapeutic drugs. I don't know, does anybody else remember that particular?
I don't remember that, but I think I can understand your example. So that's great. I mean, that's real resistance to go against that norm of, the drugs, okay, it's expensive, but, this is what we do type thing, and saying this is not, just, it's not just behavior. So we will do things differently. So I think it's a great example.
Yeah, I fully agree. I think that really condenses it into an excellent example.
Right.
Yeah, Joe, I didn't have that
something about advocacy taking responsibility. I think resistance also assumes taking responsibility. What do you think, Tasha, from your expertise?
Oh, I think it definitely does. Yeah, you're taking responsibility for creating change. Absolutely. I just had another example of the difference between advocacy and resistance, and I lost it because I liked Joe's example so much. So I didn't realize that was actually something that had happened. And so it's very concrete.
Great. Okay, should we continue a little bit? Let's continue. I think we talked about this.
So why is it not enough to just advocate in medical education? Why do we also need resistance? Because I think you need both. Sometimes you just need to work within the system and make little changes. And sometimes you need to create something completely different. And the reason is something called facticity, which is a terrible word, but it's the quality or condition of being a fact, right? We inherit the entire past of medical education when we move into this system. And I put a picture of somebody up in bondage here because I think we need to come to terms with, in this country, the entanglement between racism and slavery, and within medical education, not just racism, but also sexism and also classism. These are things that we don't often talk about, but they influence the way that we see things, the way that we think about things, and the ways that we behave. And so even though the past is something that we have not lived, and it's a system that we did not create, we are still responsible for it. So this comes back to Elizabeth's question about responsibility. So when does one's individual, I think I got this right, Elizabeth. So when does one's responsibility end, and when does collective responsibility start?
Thank
And
you.
if I got that wrong, you can go ahead and adjust it.
You okay with that, Elizabeth? She asked.
Yeah,
Okay,
I absolutely am. Thank you very much.
Thanks. It's interesting because one of the hardest things I find is reigniting or igniting, even, let's say igniting, my understanding of the past. So I have that with me as we do medical education today on topics that are influenced by the past. Because how much could you grasp of that when you haven't lived it? And the effort to grasp it as a non-lived experience is much greater than sometimes as a lived experience, like living in the moment and then bringing that forward. Is that making sense? So you really have to be a very eager learner to bring that past forward in a way that's intelligible to you and others that you're working with.
I mean, I think a good example is health inequities have been present forever. And just because we did not create the system that has resulted in this, it is part of our responsibility to fix.
Okay, go ahead.
And this is because the system that we've all come into treats some people with privilege while oppressing others, values some ways of being and erasing others, forwards some ways of thinking while ignoring others, and reproduces itself to maintain the status quo. And when I say the system, we could be talking about the healthcare system. We could be talking about the medical education system, a specific hospital unit, a department, a clerkship. You can define system any way that you want. But these systems come with them, these tendrils into our past, from our past into the present. And they're there whether we see them or not. And part of what we are meant to do is to, as Alice was saying, look at the work that we do within larger contexts, whether they're historical or social or political or economic, whatever it may be, and recontextualize what's before us within these larger contexts. So in the article, we make the claim that we believe that practitioners have a moral obligation to know when, why, and how to work for a change when a system is unjust. So we inherit the system, then we need to figure out and be armed with the tools and arm the next generation with how to resist the system when we interface with it and it's harmful to those that are participating in it. So we believe that resistance should be proportionate to an individual's ability to continue participating in a system while also working for change within that system. So it's no good if you resist so hard and maybe so publicly in some instances that you're kicked out, right? People don't want you around anymore. So every individual, whether you're a student or a resident or a physician, has to figure out how to resist the system in ways that are proportionate to the role that they play.
So just in light of that, when somebody spoke how difficult it is on a team to maybe make a change, that's really somewhat getting at this statement here.
Exactly.
Right.
Especially
And that actually could take away from resilience, because if you don't feel resilient and you constantly feel you can't make changes and that takes away from your resilience, you end up, unfortunately, getting involved in negative thoughts and disengaged in your work and all the things that go downhill from there in terms of your approach to your profession.
Yeah, we do not have to accept everything that's handed to us.
Right.
We have ways to create change.
Bruce Hirsch has his hand raised. Bruce, do you want to say something about this?
I just want to clarify the responsibility of the resistor to not threaten the overall culture or the overall health system. I'm a little bit, we were talking about resistance and for younger, lower status members of the medical hierarchy. We've mentioned a couple of provisos and restrictions. And I'm wondering if we're asking our resistors to put up with a health system that reflects some of the problems in our overall society. Would you be able to address that?
Yeah, and so specifically you're asking if we are asking medical students to accept some of the larger social problems that we're all struggling with these days?
I think so. I think we're asking medical students to be polite, to not antagonize other aspects of the health system. I think that some of the requirements to conduct oneself in a certain way might be strategic, but I don't know if it should be excluded. And I think forms of resistance that may be offensive may at some level should be welcomed in an open-hearted health system committed to the best well-being of all people.
Yeah, I would agree, Bruce. So I'm not sure what it's like where all of you work, but I was at the Medical College of Georgia for 6 to 7 years. And, we have that saying, you've seen one medical school, you've seen one. So I will say, and I don't think that this is indicative of just MCG, but I think we do ask students to accept the way that things are, even if they're unjust, and think of medicine as insulated or isolated from the rest of society, and it isn't. And I think in part that's what's got us into trouble. And so one of the things that we can do is sort of open up the system to thinking about these issues that are happening out there, because they're also happening in here. And I'm going to give you a concrete example. My last study that I did at MCG before I moved over to USU is I looked at the effect of the racial violence last summer on Black and African American physicians, because I wanted to understand how that affected them personally and professionally, because I'd heard a lot of rumors and personal conversations that it did have an effect on them, a negative effect. And one of the findings, I mean, no surprise, is that what happens out there is actually happening within here. So all of these thoughts about the dominant group sort of ignoring the needs of minoritized groups in society is also happening within medicine. And I think that as medical students, we often are politely asking them to accept some of these ways of being. And I'm not sure that that's healthy for them, our patients, the system in general. And I don't think that we can live as an insulated profession, separate from what's going on in society.
Also, I think a point that's made in the article is that it can't just be your thought and no one else agrees with you. You have to have a thought that people accept as something that needs to change. And then you need to approach it as a group, not as an individual.
It's legitimate.
And I think that is where we can start to make change. But I agree that being on your own allows the system to actually focus on you as opposed to the issue.
Right.
And a typical example, the book that we recently had our students read, Black Man in a White Coat, there was discussion of the fact that they wouldn't complain about something that's appropriate because they felt they would be labeled. So that's why I'm saying doing something on your own is risky. But if you had the correct tools to do it in a professional manner and had enough people working with you, I think that's something that the school or the hospital has to take seriously. And we need to provide those skills and tools to our students so that it can be done effectively.
Skills and tools, absolutely, Tom. I think there's also strength in numbers, which is why it's imperative that we get more minoritized physicians into our profession. So I'm sure all of you are aware, but Black women are leaving at an alarming rate once they get to the attending level, right? And these are folks that have gone through the system. They have certain perspectives and they have ways of changing the system that's imperative because they can provide some of the some ideas and insights into where we need to continue to look and change to create a system that's more welcoming for everybody else.
Okay, go ahead next.
So how might as a community we do this? We've been talking about arming our learners and ourselves with these tools and skill sets. How do we do this? Does anybody have any thoughts?
David Marcus wrote, "It must be understood that students may not come up from a position of power and that it's disheartening when they are faced with reality and are unsupported." And then Joanne said, "I agree, but this is why we need to provide a safe environment for students to come forward with their concerns."
Mm-hmm.
So maybe one of the things about teaching resistance is how to come forward with concerns that will support resistance versus coming across as maybe more negative or complaining or dissatisfied. We want to avoid that negativity piece and see resistance as a positive for change.
Yeah, absolutely. So how to come forward in a way that's professional, in a way that's recognized by the community as being valuable or important or correct or appropriate.
Bruce, do you want to comment on this? Your hand is up. Or is that from before?
I'm sorry, I don't know how to put my hand down.
That's okay. So that was from before.
I always forget.
Okay, Elizabeth, did you want to comment on this last time?
Yeah, I would like to. I think the most important thing is really, find allies and engage others. I mean, sure, there's a possibility to politely and strong go on things alone, but I would say the first is really create allies. And this is what our students at the medical school are especially good at, because this is a team taught environment and we promote team teaching. So, and peer teaching, right? So there's a really strong connection anyways. So I believe this is actually a very strong tool.
No, I totally agree. I mean, I feel it's a partnership. If we witness inequities or bias, I think we need to partner with those that are receiving these types of inappropriate comments and make that a much more stronger team to actually affect change. I mean, I was recently one of our students, and I'm not going to give the exact specifics, but there was this extremely racist nurse on the floor that apparently was quite powerful because she'd been there a long time, and everyone just tolerated it. and the student was shocked that this was tolerated. I mean, what is our role if we witness this and don't do anything about it? Especially if we're an attending and we're high in the hierarchy.
Right. What message does that send?
Right.
I think it's important to think about not just how we deal with someone that's the resistor, but I think the communication and understanding from those receiving comments from a resistor, I think, is equally important. We've been talking about how the resistor can, or someone who is resisting, how do they communicate professionally and all that. Let's say someone does do it professionally. I think the receiving end also needs to kind of accept and process that in a professional manner too. And anything that has to do with resistance is never going to be an easy conversation. So I think it takes effort on both sides.
Yeah. Wendy, I think your point is really well taken, which is part of the reason that we wanted to write this article, is because we have to have a shared discourse and way of understanding and framing what resistance is, so that if a student comes forward or a resident comes forward and attending has some understanding of what's happening in a way that they can respond to it. Because without a shared discourse or understanding, it's going to fall flat, or it's going to, so it'll either go nowhere, or it will be, it'll create defensiveness, or perhaps an unsafe situation for the learner.
I also wondered, where we talked about the importance of understanding history, I'm going back to that. When we teach resistance, we have to remember the history also. And so we have to be able to integrate that history in with whatever community we're in to better understand where the resistance is coming from.
Yes.
It's like the pre-work or the preamble.
Yes, exactly.
And if we ignore that history, we're doing a disservice. Just like if we look at the history of the development of antibiotics and where we are today, if we ignore the history, we can't appreciate the push today. You know, I don't know.
Alice, I think you can also contextualize the example into the work that you all do as physicians. So you can be handed a patient that's got a particular diagnosis, but in order to really understand that diagnosis and whether it's accurate, you have to go back into the social and medical history of that patient, right? So I think we engage in this practice in other areas in our professional lives. We just don't do it around issues that are talking about the system, not yet.
And I think that we role model complacency, which is certainly not the right thing we should be doing.
Judy, did you want to say something? Your hand is raised.
Well, two things. Actually, just to that point, like what's being described is not just education of our students, but it's actually education of our whole community. And even an extension of what Wendy said, it's not just about like hearing something that needs to be resisted, but how do we, and you know, if students or other people come, like how do we together resist, like, you know, and join as allies. And that was just one thought as we were speaking. But then one question is, I do worry that like for some people, like this idea of resistance is incredibly distressing. And how do we balance the needs of those who, you know, have within them the desire and a sense of responsibility that they want to resist and change, with those that, you know, would find that highly distressing?
Right.
I mean, I think we actually talked about that a little bit prior to this session. I don't think resistance is for everyone. There are certain individuals that they're more comfortable with this concept, and others aren't. I mean, that's true of, you know, many things in society. So I'm certainly not saying that all physicians have to take this on as their personal role. I think all physicians should be familiar with what resistance is, but there's only going to be a small subset that are willing to go and, you know, make the actual comment or the solution, because it does take a lot of courage and bravery to do that.
Tim, you haven't spoken yet, so I want to give you a chance.
Sure.
Thank you for joining.
Sure, pleasure. So I guess my thought is that to move this into sort of the mainstream of our thinking, particularly in educational environments. On the one hand, we need to integrate this concept of resistance with whatever other efforts we're embarking on with regard to diversity, inclusion, and so on, most of which are traditional advocacy subjects. I think it's helpful to have examples in discussions about change and challenging basic assumptions, to have some examples like those that have been offered here. I mean, speaking as a psychiatrist, the basic assumptions of our specialty are complicated and contribute to a great deal of the inequity in the delivery of mental health care throughout this country. And I think it's a challenging discussion that would really have us look at our basic assumptions and how we approach education and what kind of careers we're shaping our residents to pursue.
Right. Thank you. And I see David's hand up, and then we're going to go to the next slide just out of courtesy of time. Go ahead, David.
So I guess I had a few thoughts, but my main question right now was just the term resistance. I mean, the concept I understand, accept and support, and I support the term as well in general, I guess, but I'm afraid it's become very political. The term, resistance, it has a very specific political implication for many people. And I'm wondering just what your thoughts are on that, I guess, and how we integrate that.
Yeah, so we actually wanted to use that term because it is political, because I think in part what we're trying to do is to change the politics around the way that we do things. And I mean that in a very general term, not in the way, that it's typically used. But I think if anything, what the last 18 months has shown us is that we do live within these sort of contexts, these larger forces that shape our experiences within society. And these forces or matrices of power, however you describe it, have largely been ignored, right? In favor of just sort of having a very small view of what we're doing or the work that we do or how we want to be in the world. And I think part of what we need to do is to resist sort of the myopic view and scan out to look at things in a bigger field of view, and then to challenge it. I think the work that you do when you resist is a political act, and I think it should be said as much. I think the problem comes maybe perhaps with not defining what it is and not talking about it and not bringing it down to the level of practicality in skills and tools. And once we start talking about that, then I think it'll become more accepted within our community.
Do you want to go on to the next slide just out of time, and then we'll see what more we have for discussion?
Sure. So I have some thoughts for you and what you might do. So normalize and encourage learners to question how things are done. So often medical students will say, well, why do we do it this way? Or residents might bring up and say, well, can we do it this way? There's a reason that they see it differently. So just stop and take a moment to think about that and engage them in a discussion about why things are done a particular way and why might they be done a different way. When you see acts of resistance, engage in discussions on the importance of professional resistance. So I saw you do this. I saw that you decided that you're not going to use this medication anymore for chemotherapy treatment. Why is that? Engage in these kinds of discussions so that you can see what is being advocated for. It's so terrible that we have the same words to describe the things that we're trying to contrast here, but what is being resisted, and then what is being pushed for in that particular instance. And then practice critical pedagogy. If you're not familiar with this term, I would highly encourage you to look into it. So raise questions about the system so learners can begin to see ways to create change. So if you have some medical errors that have occurred, instead of just keeping the conversation at the level of the error that has occurred and sort of the sequelae that comes after that, question, why did this error occur? And I know that this does happen behind closed doors, but not always in front of learners. Why did this error occur? What is it in the system that has caused this? What can we do to resist this kind of outcome in the future. And then of course, model resistance. So anytime you see something that's harmful or unjust, a model an appropriate professional way to resist it, and then talk about what you're doing and why. So there are lots of other things that you could be doing. I'm not sure we have time for that because
Well,
we've got
if people
about,
want to put some stuff in the chat, you could do that, and I think proceed to the next slide, and we'll come back to this in a minute. I
yes,
just
so
want to give
Wendy's going
Wendy
to talk us through
1 minute just to talk about how this article went out to the academic world a little bit. Wendy?
Thank you. So I'll quickly run over the alternative metrics for this particular article, in addition to some of the metrics found on the academic medicine site itself. There were 29 tweeters that had tweeted about this particular article, which had an upper bound of over 239,000 followers. So that means that it had the potential of reaching all those people. Between this slide and the next slide, what I actually want to focus on specifically is the geographical location of where the tweets came from, in addition to where the article has been accessed. This particular page that you see here is how many times the abstract was viewed, how many times the actual PDF of the article was downloaded, and how many times it was emailed. You'll notice on both of those slides that a majority of those the locations in which the article is either accessed or talked about is very much within the US. And earlier on in our conversation, we were talking about how some individuals may not feel comfortable resisting. And I thought to myself, well, maybe it's also a cultural component. Some cultures are not naturally, kind of teaching resistance as a concept that is widely accepted and is the norm. And so it might be a far reach, but I was thinking about the map and the geographical locations, right. And perhaps it's, kind of it describes, kind of those cultural differences too, about the interest even of resistance. So those are my two slides. So if you wanted more information, please feel free to reach out to me.
Thank you. Next slide. Before we go back, if we want to put some more things in the chat, I think one thing was added. Such an important discussion from Corinne, from our MPH program leader. An important discussion. I agree both learners and educators will need to support as we further explore the topics. So that's, and that Elizabeth, I don't know if you wanted to close with your thought, that's up to you, but we will be having Journal Club, just to tell you again, on November 16th. Our one and only local medical school faculty, Sunita Sharuva, will be doing it. And thinking about professional identity formation, are we teaching resistance as part of professional identity formation? That's a really interesting question. As people develop their identity, are they thinking about resistance as part of that? So we could tie the two journal clubs together. Feedback on this is always welcomed. I get very low response, but anything you want to say to me is great. It is anonymous, and I do look at this feedback and any topic suggestions and speaker suggestions. This PowerPoint will be sent to you, and you'll have the active survey link, because this way you'll have it. So the PowerPoint is sent. I can't add the link to the chat right now, Elizabeth, but maybe, it just went in. Wendy did it. She's
got it.
So let's go back to that last question for a closing remark from anyone.
I just want to say one thing, Alice, that we may be sending out a very brief 3 or 4 question survey. So if you get it in the mail, please fill it out. It's very simple to fill out, but just wanted to collect some thoughts on this particular presentation and topic.
And Tom, do you want to bring off that idea, the last slide that we didn't get to, about the idea of complacency? Do you want to just bring that up again or not? Or you think we're okay?
I think we're okay. I mean, I just feel that happens too much when we have issues. It's the path of least resistance. Mm-hmm. And we have to really, we are physicians. We are responsible for things that happen in our hospitals and our healthcare system. And I think that being complacent is not an appropriate response to many of these things that require change.
And I want to tell you, Tom, when I worked in the Bronx, and I'm just giving from that perspective, it was unbelievable how much power physicians had in communities than other people because of their status. So, not being complacent about education systems for the children they were treating, or about, the way healthcare centers were or something. Very important, not to be complacent, and for the physicians to see themselves in roles where they could do resistance and make change.
I can give you another very quick anecdote. I just read about this, but there was a physician whose patient was having very poorly controlled asthma, and because of the HVAC system in the building, and that despite the mother calling multiple times, nothing was done. So when the physician heard this, the physician called the owner of the building personally and said that he was putting patients' health at risk, and then suddenly it was taken care of.
Right.
So we do wield more power than we think.
Tasha, you want to close us out?
I just want to thank everybody for engaging in this discussion. It seems like I'm with some like-minded folks here, and I really appreciate that. I do hope that we talk more about this within our community. So any chance that you have to talk about it, please take your colleagues up on that.
And if you think anybody should hear this conversation from a student perspective, we will be having a student discussion. It will be going out on Zoom October 27th from 7 to 8, where Tasha has agreed to come back, which is amazing, and help us with a student discussion with the student voice really being present. An amazing contrast in 1 month.
That's 7 to 8 p.m., not a.m.
Yes, I'm sorry. Thank you, Tom. Thank you. And I can't thank you enough. This was really an enlightening afternoon, midday, I should say, for us. And I give you a lot of credit for the article, and I give Rachel, of course, a standing ovation as well, even though she couldn't be with us today. So thanks.
I'll pass it on.
Okay, thank you very much.
All right, thanks everyone.
Yeah.
Be well.
Thank you.